Afternoon and good evening to all my colleagues across Europe and other regions of the world. My name is Michael Jaff. I'm a vascular medicine angiologist and the Chief Medical Officer of the Peripheral Interventions Division of Boston Scientific. And I have to tell you, I do a lot of these types of programs, but this one I'm particularly excited about, being to participate in the Clot Club with such an esteemed panel and a great audience. It really poses a lot of fun and will undoubtedly highlight several major things. One is pulmonary embolus is a serious disorder that presents in a myriad of ways with multiple challenges and different approaches for the successful management. So we'll learn about that today. The second component that we're going to understand is the importance of working as a team. This really has elevated the ability to make the right decisions for individual patients in real time. And I know that all of my colleagues on this webinar will agree this has really advanced the care of pulmonary embolus. And then the last thing I would say, and hopefully this will come up throughout our discussion this afternoon and this evening, is that we all need data. We really need data to help advance what we do, when we do it, and how we do it. Let me quickly introduce this esteemed panel of experts who are here to help shed light on this entire field of pulmonary embolus and the team-based approach. First, Professor Mariusz Tarkowski from Durban in South Africa. What a pleasure to have you here, a vascular surgeon who really has extensive experience in the interventional management of pulmonary embolus. Great to have you here, and thank you for joining. Professor Andrew Sharp, an interventional cardiologist from Cardiff. I've had a chance to work with Professor Sharp extensively over the past several years, has tremendous insight not only into the overall management of pulmonary embolus, but the interventional approaches that are available and are evolving to improve the care of these patients. Andrew, thanks for joining.
Thanks,
Professor Alexander Ganem, a notable figure in the field of interventional cardiology and pulmonary embolus, was truly the leader and author of the German guidelines on pulmonary embolus with Stavros Konstantinidis, has extensive experience in the management of PE, and really a pleasure to be working with you today, Professor Ganem. And then Professor Nicolas Meneveau, who unfortunately can't join us this evening, but has recorded his presentation, which will allow us to certainly discuss the components of that, as well as opportunities to think for the future. Professor Meneveau is an interventional cardiologist and has been extensively involved in clinical trials in the management of pulmonary embolus. And so with that introduction, just a couple of notes. First of all, the Q&A button on the bottom of your Zoom screen, wherever you are, will allow you to ask questions. Please feel free to ask as you go. And as the moderator, I'll do my best to either answer them directly in the Q&A section or ask the panel for their particular opinions on this. And then the other component that we've made live, because I think it will make it really fun for everybody, is we have kept the chat function alive. So if you want to chat with your colleagues across the region who's watching this live, feel free to do so. I'll do my best to keep an eye on the chat because I have no doubt some interesting concepts and comments will come up. So with that background and introduction, let me get us started. And it's a real pleasure and honor to go to South Africa and ask Professor Tarkowski to talk about the clinical protocol of the pulmonary embolus response team and tips and tricks of the case planned to be presented. Professor Tarkowski, the stage is yours.
Thank you very much. Let me share my screen. I'd like to thank you for the opportunity to present at the Clot Club. Let's move right on. I'm honored to be sort of among distinguished colleagues. my overview of what I'd like to do is mostly on the concept of a team, some short insight into what we have here, and then move on to tips and tricks. I think the very important and nuances and developments are going to be discussed by my distinguished colleagues. So let's define the problem shortly. Well, pulmonary embolism, it's a frequent, probably third leading cause of cardiovascular death. Similar numbers that we can see, probably 0.7 or so per 1,000 in the UK. Europe slightly higher, but there are certain cohort studies that have it at a slightly lower number of 0.4 to 0.6. However, it's still a real problem. The trouble with pulmonary embolism comes that there is such a heterogeneous group of patients, and this has been then used to come up with stratifications and different ways, and that's what the European Society has done. Pulmonary treatment, embolism pulmonary treatment has been really, I'd like to say, mostly pioneered, or at least made wide in the US, and is now moving more to Europe. And it is less recognized in myocardial infarction management, but this is what we kind of looking to be doing to establish pathways and ways of dealing with pulmonary embolism, which is a real problem. But this complex decision-making, the heterogeneous group has kind of pushed us to not having to make these decisions by ourselves, or at least not to have to make them by ourselves. And this is where the team approach comes in and becomes necessary. Now, what do we want from a team? Well, we want a very quick response to a very complex problem. And even though there are certain individuals that might be great by themselves, you will all agree that a team effort, such as the one below on the right, is what we need to have in response to complex problems. Now, who is part of a PERT team? From my reading, there is no definitive amount of members or who should be involved. There is a sort of a minimum expected of a medical physician, what we call in our country, the interventionalist, which is only the person most likely performing the reperfusion, and then most likely ICU or critical care specialists. But as you can see on here, it really pulls in a team of different departments, even as far as a pharmacy, which potentially may not have to be part of the response team, but certainly has to be very much aware of what's going on, so that the department can work together on the management of the patient. So is it really that simple? Well, it isn't really. So what is the rationale behind a pulmonary response team? Well, the rationale is as it is behind anything. And as shown in the previous slide, an effort by a team is always going to be better than the individual. The issues, though, on the pulmonary response team is their strength of data. Do PERTs really make a difference? They are still mostly in the US. They have been endorsed by the ECS guidelines in 2019. The one first defined first defined report comes from the Polish group. And there are a lot of questions that one has to ask when you look at these PERT teams. Is going to be the availability of the members. Are they part of another team? Have they been specifically formed for the response of pulmonary embolism? What is the mode of alert and communication? what is the availability, once again, of everybody for that communication, and what are the costs involved in all of this. Now, there have been some studies. This one particularly, a retrospective study, which showed that there was an improvement in the cohort of outcome in patients before the PERT era and after the PERT era. A slightly more a recent meta-analysis, which did not see the same benefit. However, they did notice that there was an increase in intervention for pulmonary embolism, and they also did see that there was a shorter stay in hospital. Once again, these papers and the methodology is so varied, meta-analyses are quite difficult. And then going back to the cost, there has been a modeling of cost of interventional pulmonary embolism, and this has shown that there is definitely going to be an increase in the use of technology. Now, the question is going to have to be, where does the money come from? And we're going to have to look at impact studies to see if it is feasible. So this is our short story. This is a hospital I work in, a nearly 300-bedded hospital with a large ICU, a large high care facility. We have some referral hospitals, but being a private center, what that means is that mostly a referral basis is on the basis of our reputation and what we provide. The team, our PERT team, consists of a physician. There are a few physicians that get involved in the treatment of these patients, but there is one particular physician that is on the team. The ICU team, which is composed of critical care as well as anesthesiology, gives us a good mix of skill. To me, they're probably instrumental in this, in the treatment of these patients, as they are always available and have a strong team presence. Vascular intervention, which is myself and one of my other colleagues, cardiology, emerging physician, and we mustn't forget that we need technologists that need to be part of this team. So we formed in about 2019, and this was really, we formed on the back of COVID and the use of ECMO. In about 2020, this started being extended to the PE intervention in our center. We were already using systemic thrombolysis for higher risk PEs, and that had developed into eventually fragmentation, the use of thrombolytic penumbra, which came to our market, left, and is now back again. I used angiojet, and this is sort of a joke, but I've used it twice, and twice times too many in my opinion. And EKOS hit our shores, and we've been using it since 2021, and probably our preferred method in patients that don't have contraindications for it. So going back to the PERT, I mean, what does one expect to achieve with it? Well, I mean, the structure has to have that element of leadership. The activation process has to be well intact, transfer, as well as communication. The evaluation process has to be through protocols. Everybody has to understand the risk assessment, the imaging, and the management has to be there for shocked patients. And we, once again, are able to for those patients, the extremists are able to use the mode of ECMO, AV ECMO, to support the patients when we consider reperfusion technology or treatment. Treatment processes, well, this depends on what we're going to use. And then later, we mustn't forget that the team also there has to be an afterthought to all of this. There has to be a transition of care to the general wards, to eventually discharge, to follow up, and to potentially following up these patients for chronic thromboembolic complications and sequelae and symptoms. And obviously, we need research, we need data, and this becomes more and more difficult, I think, in today's real world, because we all really want to have randomized trials. These are difficult. I think these are difficult because the technology moves so quickly and development moves so quickly, and this is not a problem just for this topic, but for everywhere. And by the time we do these studies, these randomized studies, they often take too long. The answers come too late, or, for example, we rush these studies, as has been, for example, in the TRACT study, which some of you maybe have known to, the Venus study, which then recruited patients too quickly and needed to do lots of sub-analyses to get answers. For the sort of the younger audience or fellows and so on, I think we need to just also understand in nomenclature. There's often in our corridors, there's often still speak of massive PE, submassive PE. I think this table highlights how this is a comparison between sort of European and American. The massive, submassive is mostly used in American literature, and the European literature is moving more to high risk and intermediate. The definitions can be looked up anywhere of that. I think in the European literature, we've added on the drop in the BP. This is all for high risk PE. A table, I think, outlining really well that the two groups that we are concerned about, which is the high risk, which are unstable patients, intermediate high risks, which are stable normotensive patients. And in short or in simple terms, the difference here is that usually there's either change in the imaging or a troponin raise, and in the intermediate low, there's only one of those and not both. So what are high risk things that we look at? Clinical scenarios. These have not been validated, but this is what we often look at patients that we are watching on anticoagulation, and these are mostly all known to you. Management of patients and how we deal with anticoagulation, who gets systemic thrombolysis shown in the slide. Contraindications, absolute and relative. These are also sometimes can be slightly adapted, especially the lengths after surgery and so on. And then, yes, then there is also, as I alluded to, the use of supportive therapy for the massive PE. Once again, going back to this, the high level evidence is lacking. There's a high recommendation for use of systemic lysis in patients with high risk. I think this is very founded and should be performed. However, this does have high risk bleeding rates. And if it is performed in centers that do not have potentially a localized catheter-directed option that can be performed quickly, I think it should be considered. But in centers that are able to expedite treatment of these patients, one must also take the risk of bleeding into consideration. And once again, it's a high recommendation, but the level of literature for that recommendation is not hugely high. How do we manage patients? And I think mostly just speaking about the intermediate high risk, usually anticoagulation, evaluate 24 to 72 hours. If they are really not improving, review. If they are deteriorating, consider then intervening on these patients. These are devices and things that we use: CDT catheters, angiovac FlowTriever, which is a sort of a Triever kind of system, a big device that is put into to catch the clot and remove it, and the other one's thrombolytic based. Penumbra, EKOS catheter, EKOS Sonic. This is the FlowTriever, which goes in and removes clot. These have had good data, and they are large systems and are slightly difficult to navigate. I've only been able to play on these models. I have not used them myself, and would love to know if the panel has. Aspirix, which is a thrombotic system without thrombolytic. once again, quickly going back to diagnosis, CTPA, it is definitely the modality of choice, available, universal, great predictive value. The risk of radiation outweighs the risk of anything else. There are different modes of scanning, and this can be seen below. We use timing, bolus, and hours. These are pictures of CT angios showing large pulmonary embolism. Here is what is often seen with these patients is that this is necrosis, a necrotic piece of lung. This is what is called the reverse halo sign with a large effusion, also which is often seen in pulmonary embolism. RV-LV ratio. All right, so I'm going to quickly get to the tips and tricks. Always use ultrasound to look at your vessels. Your options are femoral, IJV, basilic. I tend to use femoral access for patients whenever I'm using EKOS. This is because I prefer to have two sheaths next to each other. Patients don't like it in the neck because it's a prolonged length of instilling the medication. It is easy coming from the neck. It's shorter. These are often used for the more difficult to navigate devices. This is just a picture I have. This is not my picture, but I placed the sheaths, the one sheath and then the other sheath above it, which I would have done where the arrow is. This is usually on one leg. I work with a proximal sheath first and a distal sheath second, not to get into myself way. Sheath type and placement depends on your preference and device. Usually use micropuncture things to put in. Catheters that are used, Berman catheters is a Berman catheter is used with a balloon side holes. This one doesn't have an outflow. Often is a good way of starting because it can be inflated and almost navigates to the pulmonary artery. The angled pigtail catheters can also be used. The idea here is that it is twisted counterclockwise and that flips itself into the pulmonary artery. I use these, but I do find that unraveling them often can cause some arrhythmia. But this is definitely a way to start for many of the people that are starting with this. The use of contrast, lowers molar, main pulmonary artery flows, you need to go for about 30 mils per second. This is over 2 seconds, and the other ones are shown there below. I usually dilute my contrast 70 to 30, 70 contrast, 30 saline. In slightly more obese patients, 80 to 30. These are the angles that I would suggest for PE, and this is usually epifrontal for the right lung. I prefer the LOA 20 degrees for the left. That lung is slightly tilted. And lateral, usually use the contralateral approaches. You can be a little bit shallower with that. Please remember, this is for PE. I'm not suggesting this for chronic thromboembolic ones where you need better imaging. And often then you have to do more contralateral or very lateral directions. But that obviously is a lot more radiation exposure. On the right, place your side hole catheter just past the truncus arteriosus to get good pictures. On the other one is a contralateral view of the right side. This is the left side. There's no truncus arteriosus on that side, only segmental vessels. Fluoroscopy. These patients are ideally done under sedation, but often they're not able to hold their breath, and they are not able to cooperate well. But ideally, you would want them to inspire, potentially watch the lung fields, do a DSA of 5 seconds more if possible. I'm going to move to my case. This is a 63-year-old male patient, total knee replacement 6 weeks prior. He was told that significant swelling of his leg was relatively normal. He was referred. He went to a hospital from which he was referred to as at midnight. Was transferred in the morning on IV heparin. Normotensive systolics of about 100, 115, tachycardia, 60% mask. His blood results are seen here. Troponin raised. The echo showed that the right heart was certainly straining with a D sign. This is flattening of the interseptum. The patient deteriorated quite quickly throughout the day. We were not going to wait 24 hours. He went on to an EVO, or what is a nasal high flow for SATS control, and he went for intervention that afternoon. These are the pictures. This is the right trunk, almost basically blocked. On the left-hand side, a clot in the upper divisions and a clot in the lower division. The middle divisions were mostly spared. This is day 0. My approach is I got into that RV with an angled pigtail, and I left the wire in there. Now this is an approach where I have used in a very large ventricle. This is a Manny catheter. This is not very well described. It is a hydrophilic, very soft catheter, which I get over the wire into the RV, and I'm almost always able to direct the wire straight up, get it into whichever side I like, and be able to then direct the catheter over that and exchange. I find that even though there is always a bit of a risk of potentially movement around in that RV, if it's a large RV, I find that catheter works really well, and I get very few arrhythmias in those patients. This is placement of the EKOS catheter into that left side. The catheter tracks really well from the femoral. The run showing us that there is the proximal clot and clot in that lower division. Still shot of that. Introduction of the ultrasonic wire. This has to be done carefully because that wire cannot be bent. Otherwise, there will be problems with it. And once again, movement of the C-arm to make sure that we are well placed. Similar thing for the right side. And this is just wanted to show how that Manny catheter, once again, a very, very hydrophilic and soft catheter, and cannulation of the right side with a hydrophilic wire. Note it does go easily into the left side. This is now we're going to exchange that. I exchange for, in the interest of time, we exchange for a Rosen wire. And the reason I did that is because you can see this ventricle is very, very large. And I wanted to have a more steady wire that's there. For those of you that don't use a Rosen, it's a great wire. Just don't pull back on it. If it unravels, it can damage vasculature. Introduction of the catheter into that side. And once again, an angio showing quite a lot of clot in the lower division. And I'm going to move on along. Placement of the EKOS, and that was the end of the procedure. Patient was returned to the high care unit. In this case, we gave 2 milligrams of RTPA per side for 2 hours. Thereafter, went down to 0.5 per side. 17 hours of treatment until the next morning. The treatment usually is variable, but we prefer not to do treatment in the middle of the night. Makes very little sense. And if anything, we just decrease the amount of RTPA. Tachycardia resolved completely. Tachypnea resolved. He went onto nasal prongs and he felt very comfortable. The troponin had gone down, and this is at 3 o'clock that morning. So barely 10 hours after the intervention. He was taken to theater the next morning, to the angio suite next morning at about 9 o'clock. I put a pigtail in with a low pressure just to see that most of it is cleared. It's not a very good picture, but gives me an idea that most of the clot has cleared. As you see, I've left the right catheter in for the reason that's the one that's more difficult to place. this shows a little bit of clot left in the lower division. I decided not to do anything about that. On the right-hand side, there was a little bit of clot in the lower division once again. I think there must be a chronic component in this patient, knowing how long his leg has been swollen. We actually fragmented that clot a little bit and sectioned most of it out with a catheter. I don't have images for that. And lastly, we just took a picture to show how chronic this was, showing a complete occlusion and of the popliteal artery, but he had no eye. General ward had Plexane for 1 week after discharge and was changed over to a Pixiban orally. The RV had already decreased on the echo on day 2, discharged home, and will be followed up by a physician. And I've taken too much time. I apologize, and discussion now or later.
Thank you very much. Really a fantastic case that highlights so much of what we're going to be talking about. First of all, the PERT concept and the challenges and opportunities with it. That was really beautifully done. Having been in the very first PERT meeting ever in the world many years ago, I know how challenging this can be, but you already discussed the upsides. Then the case and how beautiful an example of a patient who starts off okay, rapidly deteriorates, you mobilize, offer effective therapy, and turn the patient around. So really a great discussion. I also will just thank you for mentioning the 2011 guidelines, since I was the author of those. I didn't think anybody even thought about those anymore, so I appreciate you raising that. We're going to move forward, and then don't forget the audience, the Q&A session is open, so feel free to put any questions you have in the Q&A button. And I'm going to turn this over now to Professor Sharp, who's going to give us some more insights into therapies for pulmonary embolus. Thank you, Andrew.
Thanks, Michael. That was a great start. So hopefully you can now see my slides coming up.
Yes, they look great.
Okay, lovely. Thank you. Right, so welcome everybody. I mean, I didn't think I'd see another Zoom call with about 100 people on it since COVID, so there's obviously a great deal of interest in this, so thanks very much. There's some questions that are coming in on the chat. We'll cover some of them later on. And I'm just going to talk about some data. So data can be a little bit dry, so I'm going to try and contextualize it, because there's a lot of different data out there about different doses, different regimens, how to apply it if you're using EKOS catheterlysis. Those are my conflicts of interest, which include being a consultant to Boston, and I'm on the HiPytho Executive Committee. So my case is going to be a 56-year-old lady who's immobile, who's got a borderline hemoglobin with a low MCV. We don't quite know why when we meet her. She has a history of hypertension, and she's on an ACE inhibitor and a beta blocker. A little bit against guidelines, but some people still prescribe beta blockers early on for hypertension. And she's got one heck of a pulmonary embolism. So as you can see, we have a grossly dilated right ventricle and a troublingly underfilled left ventricle. So if you see an RV-LV ratio of over 2, it's almost guaranteed your patient's in trouble. And most of them are in shock, whether or not their blood pressure is maintained or not. But young people can frequently vasoconstrict so much that their blood pressure hovers around 100 systolic until it goes off a cliff. So you've got to be really careful when you see this sort of RV-LV ratio of 2.6. And she's got acute significant pulmonary hypertension that I'll show you in a minute. She's got clot centrally, and that's always a source of great interest to us. We look at it, we obsess over it almost. I've had emergency calls for somebody with a tiny, slim saddle embolism, where the clot burden, if it embolized, would be pretty small. But in this case, we've got a pretty bulky central clot that's partially obstructing the right pulmonary artery. And you can see that there's clot in the left as well. When patients are sick like this, they've usually got substantial clot load subtending 4 lobes as a minimum. You know, it's usually subtotal occlusion on the left and partial obstruction on the right, or vice versa. So we knew from looking at that cross-section of the CT that we were going to have significant clot load. But you can also see RV-LV ratios of 1.82 with hugely dilated and impaired right ventricles with relatively dispersed clot. And so clot load does not determine the hemodynamic consequence, although clearly the more clot load you have, the more likely you are to have hemodynamic disturbance. But I've treated patients who've got widespread segmental clot with very little right in the middle, and they were in shock. So this is what I mean when you see a young patient and they have a really dilated right ventricle and they're starting to have an underfilled left ventricle like you saw on that CT. You frequently see this oscillating picture on the blood pressure chart. And this is her blood pressure chart. She very kindly gave me permission to use it. And you see how it starts at 103. That's the upper lines. And then it oscillates up and down and up and down. And what's happening is as they move around in bed, they basically go into shock. And many of you will have seen this on your coronary care units or your intensive care units. So the idea that this patient fits into a simple category like the European Society of Cardiology is a little bit opaque because there's a lot going on in this patient. And this patient is very sick and their mortality risk is high. And that mortality risk is early. And you can see how easy it would be for this blood pressure to fall into persistent shock as characterized by a blood pressure below 90. Although, of course, that's a highly simplistic way of describing shock. And I've also seen this happen a number of times in the hospital where doctors look at the heart rate and they go, well, heart rate's only 70 or 80, can't be too sick. And it is true that heart rate is one of the strongest predictors of RV dysfunction. So if you see a tachycardia in PE of 120, 130, and you can't get access to an echocardiogram, and there's no other reason for that patient to be tachycardic, I can tell you they're going to have RV dysfunction. And it will be probably quite significant. Because as the tachycardia comes down, the RV function recovers on echo and vice versa. As it goes up, you get more and more RV dysfunction. But in this case, the patient's beta blocked. And so their heart rate is being capped. So when we look at these guideline definitions of blood pressure over 90, intermediate, high risk, the risk may be somewhere of the order of 4 or 5%. It can actually go up much higher than that, up to about 25%. And if you combine different systems, such as the BOVA score, or even look at the PESI score here, which will be PESI 5, then you're looking at a risk of around 20-25% of early mortality. So how do we treat this patient? Well, I've given you the mortality on anticoagulation. Could we use just systemic lysis? Well, some people would, but note that she had an iron deficiency pattern of an MCV and her hemoglobin was a little bit low. So giving what I call extreme dose thrombolysis, 100 milligrams of alteplase, is quite a step. But if that's all you've got, that's all you've got. But maybe we can do better. So if we do catheter-directed therapy, what can we get? So here is a trial I took part in. And when I used the phrase a moment ago, extreme dose thrombolysis, 100 milligrams of alteplase was lifted from myocardial infarction and dropped into pulmonary embolism. If you think about it, the dosing regimen of giving 10 milligram bolus and then 90 over a couple of hours doesn't quite make sense, because if a patient's in shock and needs systemic thrombolysis for PE, they've got a very high risk of death in the next hour. Whereas if you look at myocardial infarction, if you arrive in a hospital emergency department and you just give them a nice cup of tea, your risk is about 13%. If you give them aspirin, it's 11. If you give them thrombolytic, it's 8. And if you take them to the cath lab, it's 4% risk of death. So the slow administration of this massive dose makes a bit of sense in myocardial infarction, because you're trying to minimize serum concentration. And your risk of hemodynamic collapse whilst you're in a hospital department with myocardial infarction is not that high, not compared to PE causing shock. In this case, this lady is not quite in shock, although I bet you a cardiac index would be low if I measured it invasively. So this was an observation that I made a long time ago, which was, why are we giving this massive dose of thrombolytic but slowly into a condition where there's very significant risk up front? And we're giving it here in the wrist and making it swim all around the body when we need it just in the lungs. So catheter lysis has some logic to it, as long as it's delivered in the right way. If we put catheters through the clot, not next to it, but through it, as we do with the EKOS catheters, as you just saw there, we can deliver clot locally, directly into the clot. and therefore hopefully increase binding of alteplase with the fibrin complex. Okay, so how do we do it? And why do we use ultrasound? Well, in my view, the ultrasound, which drives the droplets of platelets up into the clot, the principal benefit of that is to allow us to reduce the dose. And we're not the only ones who've worked this out. So in optimized PE, we thought, how low can it go? How low can ultrasound-assisted thrombolysis deliver thrombolytic? And it was tested in a dose-finding study of around 100 patients, where the first arm was 8 milligrams of TPA between two catheters over 2 hours, 8 milligrams over 4 hours, 12 milligrams over 6 hours. There was also a double-speed arm for 24 milligrams that was stopped early because of bleeding, which emphasizes that the ultrasound is making the alteplase more powerful, because 24 milligrams is quite a small dose. And yet we've seen a slight signal in Seattle 2 and in Optimize that 24 is doing a lot more than 24 would if we dripped it into a vein. And so when I use the phrase extreme dose thrombolysis for 100 milligrams, I'm justifying it by the fact that in Optimize PE, with 8 milligrams, the left-hand bar, we were able to virtually normalize the CT RV-LV ratio at 48 hours. And it occurred in all the arms. Interestingly, it was quite a flat dose effect in the sense that everybody got better. But what's fascinating is that there was a dose-related change in the PA pressure. So the more lytic you gave, the more the PA pressure came down. And when you looked at the sweet spot between resolving RV dysfunction, between PA pressure, and between bleeding, the 12 milligram arm came out pretty much the best. It's a hypothesis generating study. It's 100 patients, but we then looked in knockout PE to see how operators around the world would absorb these data. So knockout PE has just been published in Circulation Interventions, led by Keith Sterling. And what we looked at was 489 patients from 64 international sites worldwide who had intermediate or high risk PE. Most of them were intermediate high risk. And we looked at what doses were being used in the real world once we put the optimized data out there and what happened to their right ventricle. And this is what it shows. It's a slightly messy diagram. I apologize for that. But very few people were giving more than 24 milligrams in dose. So they have learned they don't need these high doses that are given peripherally, or even these historically high doses that were given by catheters. When people were just shoving a pigtail up into the pulmonary artery, you don't get that local binding advantage. It's not so different from giving it into the arm. And so in the old days, people were giving 30, 40. They were even taking them back and giving a second dose of lytic. But that's only if you've got a pigtail catheter sitting in the PA, which in my view does not make sense as a better intervention than giving it peripherally. The advantage of EKOS is that you're wiring through the clot. You're having 12 side holes that deliver alteplase droplets directly up on an acoustic gradient with the ultrasound pulsation and pulsing it into the center of the clot by thinning the fibrin strands with the ultrasound. And we've now got a second study proving that it has that effect. The first one's in press by Engelberger, and the second one is coming out shortly. And so how low can you go? Well, in the real world, between 4 and 12 milligrams are used in 30% of pulmonary embolisms, which is really quite remarkable. That's a tiny dose of lytic. And if you think about the serum concentration in those patients, the bleeding complications are going to be very low. So how low? Well, we got an RV-LV ratio improvement post-procedure. I think that's expected. We've shown in multiple studies that EKOS does that. But the difference is people are now able to incorporate the optimized data and select their dose according to the. So if you're young and if you've got extensive clot burden, maybe you theorize that if you get more clot, then the patient will have a better 40-year outcome. So maybe those patients were getting on the higher dose end to try and dissolve more of the clot. But the goal of pulmonary embolism intervention is to offload the right ventricle and stop them dying. And so if you select for a higher bleeding risk patient, like the lady I've described, the lower doses, you're going to get that effect and you're going to reduce the bleeding. And so that's, in my view, what this trial has shown us is that if you can select your dose and your protocol for the patient risk and benefit in front of you, you can get 1.6% risk of major bleeding within 72 hours, which is extremely small. That's not so different from Clexane in the original pulmonary embolism trials from enoxaparin. We had no intracranial hemorrhage in 489 patients. And these are intermediate high risk or high risk PE patients with a theoretical risk somewhere between 5 and 50%. And the mortality at 30 days was 1%. And this was a prospectively consented trial. We didn't go up to the ones who survived and say, would you mind if we used your data? We consented them before we took them to the lab. So this is a remarkably good performance. And I think it's because the judgment of operators is to balance the risk of bleeding and efficacy, knowing from the Optimize study that we're likely to offload the right ventricle. We've just got to choose the dose that we want for the right patient. And the patients did very well for quality of life. This summarizes how the dose is coming down. So we got the systemic extreme dose on the left. The old CDT papers, there was a meta-analysis that came out of Italy where it was around 35 milligrams. That's way too high when you have ultrasound with it and when you lace it into the clot. But we don't just have to rely on knockout. We have a much bigger real-world study of how EKOS is doing. So this was the paper Real PE, published by Peter Monteleone, and it was published in the Journal of Sky in 2023, and it's in press, and you can get it now. And what it looked at was the real-world experience of catheter intervention. So we have catheter-directed lysis, and we have catheter-based thrombectomy. I use them both. I think they're both excellent technologies and methods of treating patients. But it was clear that there's beginning to become a perception imbalance about which technologies were behaving in which way and with which effectiveness and safety data. So Peter looked at this and used the Truveta data platform in America, which has an enormous amount of data that's pulled at source. And it incorporates all sorts of things: blood test results, devices, procedures, outcomes, complications, everything. And this is from an 83 million patient database. Now, that's of all pathologies. So PE is only a part of that. And it was used to compare EKOS and FlowTriever. I'm not so interested in that. I'm going to show you how the EKOS did in the real world. And this is a big part of the real world. This is a substantial proportion of the United States of America. And it, as I say, it pulls from data source. I won't bore you with that. But there were two analyses done. So all data going back many years. And look at how many PEs were in this database. 500,000. And a small proportion in the real world, the United States, are being treated with devices. So you hear people talking constantly about device experience, but actually it's only a tiny number who are being treated. And that's because the randomized trial data isn't quite there yet. It's coming. IPython will be here hopefully in a year and a half. But for now, the data is clearly selective. And we have 1,600 EKOS, and we have about half the number who've been treated with the Inari FlowTriever. And if you look even at the more contemporary cohort, maybe you could argue the devices change or experience gets better. So the last 5 years were looked at within the data set. Then you have about 1,000 versus 600 between EKOS and FlowTriever. Now, as I'd expect, and as I do myself, I select patients for the different devices according to their risk benefit. So if someone has a very high bleeding risk, I might go with a thrombectomy device. If someone doesn't, then I might go with a catheterlytic. So this isn't randomized. These are just choices made by operators in the real world. And so there was a little bit of a trend towards older patients and patients with a history of cancer in the thrombectomy arm. And that's to be expected because catheterlysis might have a higher complication rate in those groups of patients if they were given a traditional catheterlytic protocol. But it was balanced for things like anticoagulation and most other major pathologies, but you can't adjust for everything. So how did EKOS do? Well, the intracranial hemorrhage rate we saw in knockout and was not a fluke, 0.3%. So that's not so different from trials of aspirin. If you look at trials of aspirin, it's about that. So again, in the real world, if people are choosing their risk benefit, you're able to deliver catheter-directed thrombolysis with a tiny risk of intracranial hemorrhage. Now, there were more signals of bleeding, and you actually saw that across thrombectomy or catheterlytic. And that's partly because the ISTH definition, which is a drop in hemoglobin of 2, it's so easy to do that. And I actually think some of these patients are hemoconcentrated when they come in the door. Again, we've got a relatively modest difference between EKOS and FlowTriever that actually favors catheterlytic. So it's not like you're experiencing substantial hemorrhage with one or the other. There were transfusion rates of 2 and 6% for the two technologies. And I think that's a better judge of bleeding, because if you're pushed to transfuse somebody because of bleeding, I think that's a more clinically significant impact. Whereas sometimes I think these patients come in hemoconcentrated with a hemoglobin of 16, it drops down to 11 after the procedures and everything else. And you just say, well, it doesn't matter so much. But what we are seeing is that EKOS is performing comparatively well to other catheter therapies, and the transfusion rate of 2% and the intracranial hemorrhage rate close to 0 is pretty good. How did they do for the big figures? So again, if you're treating these patients with catheters, they're going to be pretty sick. So in hospital death for the EKOS group was 2.6%. Remember, many of these were high-risk PE, where the mortality is predicted to be 40 to 70%, even with thrombolysis. Ischemic stroke is low, and 30-day readmission data are low, with quite a short length of stay for both arms. So again, encouraging. And it pretty much maps out the same way when you look at recent practice versus longer standing practice. So EKOS is doing pretty well. So what are the other things to think about with lytic versus thrombectomy? Well, the lytic doesn't just act in the center. So there's no doubt if you've got a massive saddle, you get a big tube up there, suck some of it out. That's an intellectually attractive proposition. But clot goes to the periphery as well as the center. And that's why frequently when I do thrombectomy procedures, I'm left with residual pulmonary hypertension at the end of it, even if I've improved it. And that's because the periphery produces a substantial amount of resistance, pulmonary vascular resistance, such that if you give lytic, you may reduce that burden of clot and resistance and get the patient back to normal. And in this study by Greg Piazza from the Seattle study, he showed that actually that with catheter lytic with the ecosystem, you were recruiting blood vessels back into play by unblocking the periphery. And that may have been a bigger factor actually than the clot reduction centrally, which intellectually to me makes a little bit of sense. So how did we do here? Well, I actually treated her with just 8 milligrams of alteplase over 4 hours. And I do this a lot in patients with bleeding risk. I'll start the infusion, I'll come back at 4 hours, re-echo them and say, how are you doing, before I decide whether to carry on to the 12 milligrams or maybe even a higher dose. And the baseline echo was 57 plus 15 on the JVP, so 72 millimeters of mercury, very severe pulmonary hypertension in this patient. That's the echo at baseline, in case you doubt me. And there's no markers here of RVH to begin with. This is just somebody who's basically on the verge of shock. And this is what happened at 4 hours. Just 4 hours with 8 milligrams of lytic delivered via the EKOS. And you can see the substantial RV recovery. Again, the long axis function, the tricuspid annulus has improved, the septum is starting to improve, the LV is filling better. And so on that basis, I decided not to give any more. Her peer pressure had come down from 72 to around 43. She's substantially improving, clinically better. Heart rate had come down by 10 points, although it was beta blocked, and the blood pressure had come up. And you can see here that things have stabilized a bit. Heart rate's down in the 70s. Blood pressure's not got that oscillating pattern. And her oxygen requirements have come down enormously. So she did really well with just 8 milligrams of lytic given over 4 hours. And so I didn't feel the need to carry on. She was off oxygen at 24 hours. And she had a CT at 48 hours as part of a research protocol. And you can see the substantial difference here in the right ventricle to left ventricular ratio. So I'm not necessarily saying we should do that for every patient. That's how I handle patients with elevated bleeding risk. I go to the 8 milligrams over 4 hour protocol of Optimize, and then I may carry on to 12 once I've done the echo at 4 hours. We're each going to develop our own method of delivering this therapy safely and effectively. But the priority is that we offload the right ventricle before they have cardiovascular collapse. Once you've observed that, and the subsequent benefits are theoretical as to reduction in clot burden and so on, the goal is to offload the right ventricle. So catheter lysis, it was the mainstay. There's been a little bit of interest in other therapies. And now most centers are beginning to balance a bit and go, okay, well, getting out big central clot with an aspiration is quite an enticing prospect, and sometimes it works very well. But catheter lytic works on the periphery as well as the center, and that may be important, particularly in cases like this where there's very high pulmonary artery pressures. Her left side was 100, her right side was 72 millimeters of mercury. You do that, and you're in trouble. Safety data are very good in real-world practice, and I think that's because people are choosing their doses for the patient that's in front of them. RCT data are coming, and we're going to get there first in Python with EKOS. This is going to be intermediate high-risk patients with features that trouble us, like tachycardia, relative hypotension, hypoxia, and we're randomizing against anticoagulation. And I think this is the first big outcome study over 500 patients, and that's coming about a year from now. And I think if that's supportive, that's going to cement catheter therapy at the heart of the treatment of sick PEs. And the EKOS version of catheter-directed lysis will be the proven technology if the trial is positive. There's other trials coming as well. It really is a great time for pulmonary embolism research. So thanks very much.
Thank you, Andrew. Outstanding as always, and appreciate the insights on how troubling many of these patients appear and how quickly we have to act in order to turn a really disastrous situation around. I'm going to go right to you, Professor Ganem, based on time, so that we can hear your perspectives on how you use the new German guidelines for case management. Thank you.
Yes, thank you very much for having me, and it's a pleasure to be with you. Of course, we have good guidelines on the European level, but Germany is a very special decentral healthcare system. So we tried to put up our own perspective, and the co-chair of this committee was Stavros Konstantinidis. So you will find a real global perspective in a German paper. So first of all, I would like to present you a case which we treated along these guidelines recently. It's an 80-year-old female. She was immobilized due to lumbar spine fracture as she was waiting on the waiting list 2 months, and she had sudden onset of chest pain, shortness of breath, and came to our hospital in right heart failure with troponin and BNP elevation, right ventricular failure. And it was not as impressive as the case of Andrew Sharp, but I will show you the initial echo. Although the initial echo was really impressive, the news score was not. So she came to us in the first level of monitoring without any pressure. She had stable vitals and good respiration rate. So we were not very, let's say, we have no fear that she will have a bad outcome. So we put her on heparin, put her on a monitor, and monitored her for her news score. This was the echo, which was quite impressive in my perspective, and it was not corresponding to the news score. So normally this echo is preceding news score, and you can really read out of this echo that this patient will have trouble in a very short amount of time. However, we all have experience in patients that react to the first heparin bolus, so we were quite sure to give her time to react on anticoagulation. However, the patient was not doing well on heparin. She had a metabolic collapse and she had a gas collapse, so she had less saturation and she was less vigilant, and we put her in the cath lab after CT. So after echocardiography and CT, we were quite sure that this patient needed CDT. This is the quick run through, and I will point out the fresh thrombus in both lower compartments of the pulmonary arteries and a free bifurcation. So in our perspective, she was a very good case for EKOS, as the central acute pulmonary embolism was detected, and she had an incipient decompensation on a very fast clinical perspective. So within 2 hours, she slithered into the high risk group. So we did angiography and placed the EKOS catheters deeply inside the clot on both sides, and had 2 days of intermediate care. It was Optalize arm, group 3. So we had 6 milligrams, 12 milligrams in 6 hours, and were able to put her on monitor after 24 hours, initiated apixaban on day 3, and had a good improved right ventricular function and normalized RV/LV, and put her were able to let her home on day 6. So how was the German guideline constituted? So we were very sure that there are these big amount of patients doing well on anticoagulation, and these really clear-cut high-risk patients which need to be on lysis. So we concentrated on patients prone to be collapsing, and we highlighted these patients on a hemodynamic, on a respiratory, and on a metabolic level, and prone for collapse of an intermediate to high risk pulmonary embolism went to the report to the PERT. And as in Germany, many centers do not have vascular surgeons or cardiothoracic surgeons on site, we let it free to put the PERT together by, let's say, cardiology, radiology, and intensive care unit, and to use the infrastructure you already have, let's say chest pain unit. And we put this multidisciplinary pulmonary embolism team on a very structured approach of information. So vital signs news, echo, and also the biomarkers. And we put these patients in a review process. So they will be re-reviewed by the pulmonary embolism response team in a secondary survey. And this secondary survey is a secondary risk stratification, and we would like to have the ambivalence of the risk of death due to pulmonary embolism, intermediate, high, and excessive risk, and also put in context to the hemorrhage risk. So if you are on a very low risk of hemorrhage and a high risk or excessive risk of mortality, we felt very free to do intravenous thrombolysis in an intermediate to high risk patient which is beginning to collapse, or on the other side, patients with intermediate or high bleeding risk, or even anticoagulation contraindication. We were free to opt for CDT, let's say EKOS or thrombectomy. So this secondary survey was very important to us, and to put it in a scientific context, we would like to go through this evaluation of the second survey with you based on this 80-year-old surgical patient. And if you say, let's say, you take the Optalize protocol and you take this arm 3, you have a very acceptable bleeding rate with a very acceptable intracranial hemorrhage rate. So we felt very good to do this peripheral bilateral pulmonary embolism on EKOS treatment. And if you want to have a, let's say, prospective evaluation of effectiveness, you can have a look at the thrombus burden reduction in the trials. And we compared the thrombectomy, where you can, let's say, yield a very good clot retrieval because you pull it out of the pulmonary artery and put it on the table. So you have a very good feeling of being effective. And in these registries, FLAIR or extract, we have a comparable thrombus burden reduction as to most used EKOS protocol, let's say the 612 protocol in the Optalize arm 3. So we had a very good balance of efficacy and safety in this perspective of this individual patient, and we treated her evidence-based based on the second survey and based on this really incipient hemodynamic and respiratory collapse of this patient, which initially came with a very acceptable intermediate to high risk pulmonary embolism. So she had a very fast course. So we were very happy to have this 24/7 survey in our chest pain unit where the PERT can react very fast on these patients and individually treat these patients. So we built 3 new structures in a first, second survey, and the persons needed to evaluate these patients twice, initially and in follow-up. And we opted for EKOS treatment. So we had a good treatment algorithm, which we can still use 24/7. So not only Wednesday morning, but also Saturday night, patients have the same treatment based on the balance of mortality and therapeutic risk. So it's not only myocardial infarction or stroke, which are emergencies, as you can see here on the German emergency department, the car of the German emergency departments. It's also the pulmonary embolism, which is an emergency, and these treated patients and their happy faces with the doctors treated them show you that we are on the right track, putting pulmonary embolism on the level of myocardial infarction and stroke. Thank you.
Well, what a great presentation where you really did tie guidelines to how to make clinical decisions. That was fantastic. And I do love that van. That is a great idea. We have those in some regions of the United States for stroke care, but not for PE. So it's a very interesting idea. So thank you for that. Just for the sake of time, so I leave a few questions for the faculty, we're going to go right to the video recording of Professor Meneveau to give his examples of PERT and pathways leading to an EKOS case.
Thank you for the invitation to attend this meeting, and forgive me for not being able to be there with you. I had to pre-record my presentation. Thank you for your understanding. Let's illustrate with a clinical case from daily practice. This is the case of a 73-year-old male who was referred to the emergency ward for syncope and acute dyspnea lasting for approximately 8 hours. He initially presented without hemodynamic instability and without systemic hypotension. At initial presentation, the patient is tachypneic and there is no elevated lactate level. The ECG recording confirmed the tachycardia and indicated complete right bundle branch block. The CT scan confirmed the diagnosis of acute bilateral pulmonary embolism and revealed the presence of thrombus in the proximal right trunk and in left segmental arteries. Baseline echocardiography reported criteria of acute right ventricular dysfunction, including an RV-LV ratio of 1.5 and RV to right atrium pressure gradient of 50 millimeters of mercury. PE severity was classified as intermediate high-risk PE according to early PE-related risk. The patient was then hospitalized and monitored in the ICU, but at 12 hours he complained of dizziness and his clinical state was deteriorating with a systolic blood pressure of 80 mm of mercury, pulse oximetry of 85%, and elevated lactate levels. Systemic hypotension and elevated lactates defined high-risk PE. High-risk PE includes a wide spectrum of clinical conditions, from sustained hypertension through cardiogenic shock to the most severe presentation, cardiac arrest. Therefore, we have several management options, including PERT activation, pharmacological treatment of acute right ventricular failure, cardiopulmonary support with VA ECMO, and the reperfusion strategy. Then the first question is, what would you do first? Is PERT activation needed at this stage? The concept of a PERT stems from the heart team approach, which plays a key role in optimizing the management of patients with acute cardiovascular disease while promoting shared decision-making. And this is important because the treatment is based on low level of evidence, and also because these patients are frequently managed by physicians who are not always expert PE clinicians. The PERT has been developed and is recommended to improve time to treatment and coordination of care pathways. Data from observational studies report that PERT is associated with greater access to advanced therapies and a lower 30-day mortality rate, hospital length of stay, and in-hospital bleeding complications. Therefore, there is a consensus that PERT is recommended in high-risk PE patients. In this prospective single-center cohort study, the composition of PERT and in-hospital PE-related mortality were investigated. In total, 42% of patients were classified as intermediate high-risk PE and 11% as high-risk PE. First PERT contact mainly originated from emergency departments, followed by chest pain units and regular wards. Cardiologists or cardiac surgeons were included in almost all PERT consultations, followed by a radiologist and anesthesiologist. In addition, PERT implementation was associated with lower risk of all-cause mortality rate. In this meta-analysis, PERT implementation led to greater use of advanced therapies and shorter in-hospital stay, but did not show a survival benefit in patients with PE since PERT implementation. Back to the patient, heparin plus cautious volume loading and administration of two vasoactive medications for 30 minutes did not restore hemodynamics. Now the questions are, is ECMO indicated? If yes, what's the strategy behind its use? Or should we consider a reperfusion strategy first? It was decided to start with VA ECMO implantation before considering a reperfusion strategy. The application of ECMO in this setting allows for stabilization of hemodynamics, leaving time to evaluate further treatment strategies. Data from the literature suggest that in patients with refractory cardiac arrest, refractory shock, or resuscitated cardiac arrest, VA ECMO should be considered either as a bridge to decision and reperfusion strategy, such as percutaneous thrombectomy or surgical embolectomy, or as a bridge to recovery after surgical embolectomy in patients with persistent right heart failure. I think it's important to emphasize that indications are not based on prospective randomized trials, and that deployment is often driven by a clinical judgment that the patient is unstable with a risk of imminent death from cardiopulmonary failure. There are poor prognostic factors that need to be considered, especially cardiac arrest with unknown no-flow duration. We performed this meta-analysis focusing on the optimal reperfusion strategy in patients with PE requiring ECMO. And then you can see here that the mortality rate was lower in patients treated with mechanical embolectomy than in those treated with either thrombolysis or those treated with standalone ECMO. Similarly, the bleeding rate was lower in patients treated with mechanical reperfusion than in those treated with either thrombolysis or standalone ECMO. So getting back to the patient again, the management strategy was discussed within the multidisciplinary PERT. Systemic thrombolysis was ruled out due to the intracranial bleeding risk. According to the European guidelines, a percutaneous approach using catheter-directed treatment was discussed, and catheter-directed mechanical thrombectomy was not considered because of anticipated difficulties with femoral access due to ECMO placement. The decision was then taken for catheter-directed thrombolysis following ECMO placement, which is associated with a low risk of intracranial hemorrhage. The EKOS system combines local thrombolytic infusion with ultrasound assistance. The EKOS system consists of 3 components: an infusion catheter, a removable microsonic device containing multiple small ultrasound transducers, and the new EKOS control unit. The infusion catheter is provided with multiple side holes and with 2 different ports. One port is used for saline coolant infusion, and the other port is used for TPA infusion. Venous access was achieved under ultrasound guidance via the left basilic and cephalic vents using 2 6-French sheaths for the catheter-directed thrombolysis insertion. An IV bolus of unfractionated heparin was given, followed by continuous infusion. Catheters were inserted in the main and lower lobe of the pulmonary arteries in the cath lab under fluoroscopy, and a bolus of TPA of 5 mg per device was given. A continuous infusion of TPA at 1 mg per hour and of saline coolant associated with ultrasound delivery were then initiated for 8 hours, corresponding to a total dose of TPA of 26 mg. The patient was then monitored in the intensive care unit for 48 hours. The patient's in-hospital course was favorable, making it possible to discontinue the inotropic drugs. An improvement in ARV function was observed within the first few hours after CDT, and weaning and decannulation were performed after 72 hours. Well, to conclude, I would say that the use of ECMO in PE seems to be reserved for the most severe patients among those at high risk, including cardiac arrest and refractory shock. The complex management of these patients requires urgent yet coordinated multidisciplinary care, including PERT and ECMO teams. The challenges consist in identifying the reperfusion strategy behind the use of ECMO, and the use of ultrasound-assisted thrombolysis is an effective, safe, and easy-to-use alternative for these patients, even those at high bleeding risk. Thank you for your attention.
That's a great presentation. So we've got about 9 minutes for some questions. So maybe we can take these slides down so I can see Professors Ganem and Sharp a little bigger. And I want to say to the audience, if you have questions, please put them in the Q&A. I want to start off with you, Andrew. In your procedural role, what's your dosing of IV unfractionated heparin during and following an EKOS TPA infusion?
Thanks, Michael. We don't have the strongest data to support the dosing. We looked through this when we were designing the HI-PEITHO protocol and decided on 300 to 500 units an hour. And this is a patient who's typically going into the procedure fully anticoagulated, either with Clexane or with subcutaneous enoxaparin or with intravenous unfractionated heparin. So the basic principle is reduce the dose of it. You do need some heparin around because, as you know, as you lyse fibrin, it can reconnect and rebind platelets. And so heparin will prevent that, or at least reduce the risk of that happening. And so we've gone for 300 to 500 in HI-PEITHO. Throughout my career, I've done around 500 units an hour, and I drop it if there's somebody of very low body weight. So roughly, I've been doing what we've decided to do for HI-PEITHO.
Great, thanks. Professor Ganem, I wonder, there are people undoubtedly in Clot Club today who are interested in getting more involved in the management of this broad population of PE patients. If you were going to advise a group that doesn't have a PERT yet on how to get started, what are some of the things you've learned that could be helpful to the audience as they start to plan for this?
Yeah, this is an excellent question. So looking back, in my perspective, it needs two components which make habits easier to stick. So the one thing is you need structures that are already established, and you just stack on these structures new substructures. So let's say you have a chest pain unit. You use it as a central where all the information is gathered and where it's a little bit like the little brain of the PERT. And it's also some kind of a catalyst for persons getting involved. And this is the point where I get to the second component. You need driven and motivated people who believe in the method of doing more than necessary. So, of course, you can say, this is intermediate to high, put them on aspirin, and fingers crossed, next day dead. Okay? You still are on your guidelines and you did nothing wrong. And so you need people who believe in there's still something potentially better than the status quo. And I think this is the combination. Stacking habits on already established structures and having people who really drive the program.
Those are very important points. I can tell you that what we learned when we started our PERT at Mass General was you can't force this. You want to get physicians who come with different perspectives but are willing to participate. Be open-minded, understand the opportunity to learn from each other, and also to speed up the treatment when advanced therapies are required. And I think those are keys as you're starting out your program. Andrew, congratulations on your imminent move to Ireland. I know you're going to a place that has a mature PERT already, but what are the opportunities that you see for even academic centers to advance what they do in their PERT for the management of PE?
Well, we've never had so many clinical trials that we can recruit to. So that is a massive opportunity. And I think this is a golden era of clinical trials, but not just that, is it's going to trigger on a second wave. With EKOS, we have EKOS Plus coming, which may be able to deliver catheter lysis in just a couple of hours with similarly very low doses of lytic. So that's being studied in sonic PE in the United States, and then a new wave of catheter-lytic trials will come after that. If HiPytho is positive, then I think it changes the way all PERTs run around the world. And we're all going to have to get used to the fact that we'll have level 1 data that shows that this idea of put patients on normal echo or heparin and wait until they're falling apart is not the right strategy. If they have predetermined risk factors, and we're looking at tachycardia, low normal blood pressure, raised respiratory rate, hypoxia, then those patients should be considered up front. Now, obviously, the beauty of PERT is that we don't follow formulas. We have this coalition of the willing of experts from different perspectives, some of whom are highly conservative, some of whom are quite interventional, some of whom are used to dealing with very sick patients, some of whom are not very comfortable dealing with patients with instability. And so it's an interesting thing how each different center has a different flavor to their PERT according to who's in it. And as you say, you can't force it. You've just got to say who's willing to come and look at these patients because they're difficult. You know, if you've got somebody who's neutropenic, who's on some anti-cancer drug, who's in a side room, who's had a pulmonary embolism, whose platelet count is 70, these are very difficult, individualized, nuanced decision-making. So yes, the clinical trials are going to push forward the concept of catheter interventions, but we're still going to need that mix of opinions. So I'm delighted to join the Matter pulmonary embolism team, who are already consist of intensive care, respiratory medicine, interventional radiology, intensive care. Cardiology will come. I hope I'll be able to bring easier access to cardiac assessments. I think echo is crucial to the assessment of a pulmonary embolism patient. And so the fact I can do that myself is helpful. And, you know, we're just teasing our way into this era. It feels like these catheters have been around forever. But actually, if you look at the true beta data I showed, and now we see the trials, this is the beginning, and it's exciting times.
Professor Ganem, I know we only have a couple minutes, but two really good questions that came in from the audience. First of all, is there any role and value of using measurement of direct pulmonary artery pressures during EKOS or during an intervention to determine when you stop therapy?
I think there could be an added value in continuous monitoring of pulmonary pressure. However, in my perspective, it's not really needed because echo is a very good readout, and in my perspective, it's also prone to complication if you have too many catheters stick in the pulmonary vasculature. So I'm not really convinced. So let's say the EKOS system takes the pressure and you have buy one, get one free system. This could be nice. And maybe AI is allowing us to find the sweet spot where we turn down EKOS, where risk-benefit stops. And however, in really acute pulmonary embolism, in my experience, it's not these excessive high PA pressures. It could be only a 45, which makes a real problem. And these acute and chronic patients, which are often described and which make our work really interesting, I think in these patients, it could be of added value to have a continuous pressure trace.
Great, thank you. Well, I know we're running short on time. I'm going to hit the two questions that just came in. When do you expect patients to get better after EKOS, or when to decide to stop EKOS? I think there are a lot of different ways to think about it. You just heard Professor Ganem gave a great answer on how to make clinical judgments, how to use echocardiography. But the truth of the matter is the patient's going to tell you. They feel better. You're going to use a protocol that works for you, that's based on the literature, and make your judgments accordingly. And then the second question, do you use EKOS on every patient with intermediate and high risk? I think the answer to that's clearly no. There is no therapy that any of us do in any cardiovascular condition where you use the same thing every time. And so there are lots of nuances to this, and that's why it's fun to be involved in pulmonary embolus care. And I just want to take a moment to thank the faculty, to thank Leo for scheduling this. This has been a great Clot Club. I'd love to do one of these in person in Europe someday, Leo. That was just a plug. And I want to thank everybody for joining us today, and I hope you found this as informative as I did. Thank you all very much.
Thank you.
Thank you.